Hi, welcome to today's webinar. Thanks for joining in. We have a few announcements before we get started. The Johnson Center hosts free webinars throughout the year. The next one will be next Tuesday, April 9th, when I, Dr. Rundle, present part 3 of this 3-part series. You can see the full list of upcoming free webinars by going to www.johnsoncenter.org, johnson-center.org, then clicking on the webinars link on the right-hand side. You can also sign up for our email list and stay up to date on all the events and opportunities by clicking on the Join Our Email List link on the homepage. We currently have some terrific programs to provide assistance for families and children, including grants and sliding fee scales for diagnostic services, counseling support, sibling camps, and more. If you'd like more information, please contact us at info@johnson-center.org. These support programs are funded by community support, and in honor of April being Autism Awareness and Acceptance Month, we will once again be hosting an online auction to raise critical funds for these grant support programs. From April 15th until April 30th, you'll be able to bid on hundreds of items, and 100% of the proceeds will go directly to family support grants. The auction goes live April 15th, so be sure to check it out at takeactionforautism.org. Follow our colleagues at the Autism Research Institute, as they also host several great webinars and share some great resources on their website and social media pages. If you'd like a certificate of attendance after today's webinar, look for a follow-up email in your inbox 1 hour after the webinar concludes, or look for the link on our YouTube channel in the webinar description. It will contain instructions on how to get your certificate. If you have questions during the live webinar, please type them into your GoToWebinar control panel, or you can email info@johnson-center.org. If you're watching a recording of this webinar, you can email questions to the presenter at info@johnson-center.org. Be sure to check out our library of past webinars on our YouTube channel at youtube.com/The Johnson Center. So I am hosting today's webinar. I'm Dr. Jana Rundle. I'm a clinical psychologist here at the Johnson Center. I specialize in diagnosing and treating autism. I'm also an individual therapist, so I do a lot of individual therapy with both kids and adults. I'm really trained as an individual therapist, so most of my training is therapy-based, which is why I'm doing this series. Last Tuesday, a couple days ago, we did the anxiety webinar. Today, we're focusing on depression. And then next Tuesday, we will focus on sleep. And they're kind of designed to be related to each other. The symptoms kind of overlap, the treatment overlaps. And so today, we're going to focus on depression. I'm very excited. Let's get started. All right. So I want to start by answering some questions from the previous webinar. I thought they were really good, so I want to hit them right now. So the first one was, what do we know about the benefits of physical touch for relieving anxiety? And I really didn't talk about this in the last webinar, but I do think it's important to talk about the benefits of physical touch. So there is a lot of research in this area, actually. There's research on massage and the benefits of massage for relieving stress, even in cancer patients and chemotherapy patients, and the benefits of receiving massage throughout chemotherapy treatments. So there's a lot of benefits on physical touch. One of the things that I think is really interesting is the study that was completed in the 1950s and 60s from a psychologist named Harry Harlow. And you might have heard of this study. It's very famous. It is Harlow's monkeys. So Harlow had an interest in kind of how we connect to our caregivers and whether connection and social connection is due to nourishment and a parent or caregiver providing milk or food to a baby, or whether it's something else going on that helps us connect to our caregivers. And he was really interested in monkeys, and so he had a laboratory with a lot of monkeys and looked at kind of how monkeys attach to caregivers. So for him, he was more interested to see like what would be the effects of deprivation. This study would never be allowed to happen in this day and age, but this was, you know, a while ago. It was in the 50s and 60s. So this study would never pass an internal review board, an IRB committee, just because it seems a little inhumane when we think about it today. But I think really interesting stuff came out of it. So what Harlow did was he had a laboratory with a bunch of monkeys. He removed them from their biological mother. He placed them into separate cages, and then he had a wire mesh mother, and then a mother that was a cage wrapped in terry cloth, something soft. And he looked to see what the monkeys would do when they were face to face with this wire mother and the cloth mother. Not surprisingly, the monkeys preferred the soft cloth mother. So then he decided to look at, well, what if the wire mother is the mother that provides the nourishment? So what if the wire mother is the one that they can get milk from, and the plush mother is just there too? What happens then? Also, not surprisingly, the monkeys still preferred the cuddly, soft, warm mother. So even though they would get food from the wire monkey, they would still go to the soft monkey to hang out, to cuddle. If they got scared, they would run to the soft monkey. And so that basically shows the importance that we place on comfort, on something soft. If you think about in today's world, when you have an infant in the hospital, back in the day, they used to rush the infants away and place them into nurseries in the hospital. Well, now they don't do that. They like to place the infants on the mother's chest for that skin-to-skin contact, because they know that that physical touch, that skin-to-skin contact, releases really important hormones that we need for appropriate development. So we really know that physical touch is really important. If you've researched any of the Ukrainian orphanage studies, we know that depriving infants of social contact and connection and care is really detrimental to development. So physical touch, very, very important. And I'm not sure if the question was really focused on autism specifically or just people generally. So we know people generally respond well to pleasurable touch. Of course, there are some touches that are unpleasurable, especially touches from a stranger or painful touches. We know in the autism community that kiddos are more sensitive to touch. So the studies really show that if you compare a control group, so kiddos without autism with kiddos with autism, and they rate different touches, the kiddos with autism rate those touches as unpleasurable or less pleasurable than their counterparts. So we know that kiddos on the spectrum are sensitive to touch, but that doesn't really negate the rest of the research that really shows that physical touch is really important for our development. You know, that skin-to-skin contact releases a really important hormone called oxytocin, which if you research oxytocin, a lot of the times in the media, they call it the love hormone because it's a really important hormone for our emotional bonding. That's why they put the babies skin to skin, because it helps release that bonding hormone that's really important for both the babies and the mothers. Oxytocin, I had this professor in graduate school who used to say that if you wanted your partner to remain faithful in your relationship, to get them some nasal spray oxytocin that they could take, because it's the bonding hormone. It helps us bond to our partners. It also releases, it's a neurotransmitter, so it affects, you know, how we feel too. So there's a lot of research on the benefits of physical touch and pleasurable touch, decreasing those cortisol levels, the stress hormone that we talked about last week, and increasing positive neurotransmitters like serotonin and dopamine. So for most people, I think pleasurable touch is really beneficial. Where we get, there's that kind of fine line in autism on whether something's pleasurable or unpleasurable. So I think when we're thinking about autism in our kiddos who are really sensitive to touch, it's just important to find the touches that are pleasurable to them. In general, I feel like kiddos on the spectrum like a more firm touch rather than like a lighter touch. So it's just important to figure out kind of what works for your kiddo. But I did think it was a really good question, and I wanted to hit on it. The next question was, it was kind of related too. So let's see. Next question. Okay, what do we know about intimacy and anxiety? Is having close relationships proven to be helpful for anxiety? So there's also a lot of research on this topic that I think is really interesting. So there's a longitudinal study out of Harvard that looked at factors related to longevity. In a longitudinal study, all that is means that they take people and then they look at them for a long time. So that's what a longitudinal study is. It just means that they're following their participants over a long period of time. So this particular study started in the 1930s. It followed participants throughout their lifespan. So there's still several participants from this study that are still alive, but they're in their 90s at this point. So this study was really able to look at several factors that led to longevity in this particular sample. So they looked at a variety of factors. They looked at health factors, but also looked at other factors related to our lifespan, like careers, like relationships. So to see what factors led to happier lives and what factors led to longevity. And what they found was that close relationships, more so than money or fame in their careers, were what really kept people happy throughout their lives. So relationships are really seen to protect people from life's discontent. They also showed that people who were happy in their relationships had less mental health issues, less physical decline, so that relationships were a better predictor of long and happy lives, more so than social class, more so than IQ, or even genetics. So relationship satisfaction in midlife predicted longevity better than even some health-related factors like cholesterol. So when they took a 50-year-old person and participant and looked at their cholesterol level, but then also asked about their satisfaction in their relationships, if they were satisfied in their relationships, they were much more likely to be healthy at age 80, which is really interesting. So one of the researchers from this study ended up doing a TED Talk about it, and I'll put the name of the TED Talk on one of the later slides if you ever care to watch it. I think it's really interesting. It's about 12 minutes long. It's called What Makes a Good Life? And we don't really have time to watch it today, but Google it and watch it later if you're interested. But it talks about this study and what kind of factors came out. And in the TED Talk, the researcher said, loneliness kills. It's as powerful as smoking or alcoholism. So in their study, they kind of found out that the people who were satisfied in their relationships ended up being much better physically than people who were unsatisfied in their relationships. And it's important to note too that, you know, satisfaction is a key. We have tons of relationships throughout our lives, and many of them can be toxic or unhappy. So really what this research is showing, that people who are satisfied in their relationships end up being physically better and emotionally better. But it's important to note that people who are unhappy or lonely don't get those same benefits. When we're thinking about autism specifically, you know, social deficits are part of the kind of hallmark symptoms of autism, but that doesn't mean that people on the spectrum can't have meaningful relationships. And really, it doesn't necessarily mean romantic partners. This research kind of showed as long as you are satisfied with the relationships that you have, whether that's family, whether that's friendships, whether that's relationships in your career, or, you know, finding a sense of meaning and purpose in relationships is really what they found. It doesn't necessarily need to be an intimate romantic partner. So I think that's important to note, that our family can bring us just as much, family and friendships can bring us just as much satisfaction as intimate relationships can, or romantic, I should say, because family and friendships are a level of intimacy as well, just a different, not a romantic intimacy, I guess. All right, so what's our agenda for today? Today we're talking about depression. So we'll talk about what depression is, We'll talk about depression and autism spectrum disorder. We'll talk about diagnosing and some of the difficulties with diagnosing depression, especially when it comes to ASD. And then we'll talk about treatment. All right, so what is depression? Depression is a diagnosis. It is a label that we use to indicate clinically significant sadness that interferes with functioning. So the manual that psychologists use to diagnose is called the DSM, the Diagnostic and Statistical Manual. It's currently in its 5th edition. So the DSM-5 kind of lays out the symptoms of depression. And you need 5 or more of these symptoms in the same 2-week period. So basically, in order to meet criteria for a diagnosis, you have to have 5 of these following symptoms over a 2-week period. So depressed mood most of the day, nearly every day. That makes sense. In order to qualify for diagnosis of depression, we have to have a low mood, a depressed mood. Also, marked diminished interest in pleasure in almost all or all activities. So diminished interest in things that you used to enjoy. We call that anhedonia is the word for that. Weight loss or weight gain, or appetite loss or appetite gain. It's interesting to me how some of the symptoms of depression are opposites. So one symptom of depression can be appetite loss and therefore weight loss, or appetite gain and weight gain. It's kind of different in different people and how they handle the symptoms of depression. Also, hypersomnia, which would be sleeping too much, or insomnia, which would be not sleeping enough. Another opposite. Here comes another opposite at you, either psychomotor agitation, which is like moving around too much, or psychomotor retardation, which would be like moving really slowly. Fatigue or loss of energy, worthlessness or inappropriate guilt, diminished ability to think or concentrate, and then finally recurrent thoughts of death or suicidal ideation. So you need at least 5 of those symptoms to meet criteria for having a major depressive episode, which would be like major depressive disorder, which is a lot. I mean, depression is a significant diagnosis. It is, it's something that I feel like if you're reading these symptoms and you feel like you're checking off a lot of them, it's something that really warrants some attention, especially because the association of depression with thoughts of suicide. It's something that's, you know, really serious, that if you're having a depressive episode, it really warrants attention and treatment. So one of the hallmark kind of cognitive styles of depression has been shown to be related to one's style of thought, meaning how one processes incoming data and information around them. So this idea that the way we think affects our mood. So meta-analytical studies, which meta-analysis are studies that look at a lot of research in one area. So they'll, you know, take a topic, let's say depression, and then they'll look at all the research that's available on that topic, and then they'll analyze it, and then they'll present their meta-analytical data. They have discovered, these meta-analytical studies have discovered the association between rumination, which is perseverative negative thoughts, thinking about something over and over again. We talked about that in the previous webinar on anxiety, but that rumination in psychopathology was stronger than any other process assessed, indicating that rumination specifically is linked to more severe mental health symptoms than a lot of other things that they analyzed. So just that tendency to think about negative things over and over and over again is strongly linked to both the vulnerability for depression and the maintenance of that depression. So the kind of thought styles that we have can really be a factor in how we feel and the symptoms that we experience. So recent research has shown that individuals with autism may be 3 times more likely to have episodes of depression than the general public. So research published in 2018 indicated that in their study, 19.8% of young adults with autism have a history of depression, compared with just 6% of the general population. If you remember from our webinar on Tuesday, I also talked about the increased prevalence of anxiety in the autism spectrum disorder population. So with anxiety, it was 25 to 85% of individuals with autism have anxiety, as compared to 1 to 7% in the general public. Well, that was research on kids specifically, but still relevant. So depression is the same, where the incidence rate of depression with ASD is way higher in the ASD population than in the general public. And we're going to talk a little bit about why that is. I think there are several factors involved, but it is important if you have a loved one with autism or someone that you know with autism, that you're paying attention to their experiences, that you're paying attention to some of their behavioral expressions, because we know that there's a higher rate of anxiety and depression in this population, and so it's really important to be aware of what to look for and also what treatment is available for treating these things. So higher functioning individuals are also seen to be a greater risk for developing autism. I saw several studies that indicated this, that, you know, we used to have a diagnosis in the DSM-4 called Asperger's that's not there anymore, which is not a topic for today's conversation, but that's kind of, there were several studies that looked at individuals who had an Asperger's diagnosis and how they were seen to be at a higher rate of developing depression than even some of their lower functioning. This could be because higher functioning individuals may have more social competence, may be better able to understand that they're different, that kind of knowledge that, hey, I'm different than my peers, which could lead to feeling bad about yourself, low self-worth. So that's kind of why what researchers speculate is going on with the higher rate of depression with higher functioning kiddos on the spectrum. So let's talk a little bit more about depression and autism. Recent researchers have speculated that the higher rates of depression seen in individuals with autism may have to do with that perseverative thought process that's a core symptom of autism. So we talked about, too, in the anxiety webinar, one of the symptoms of autism is having a difficult time getting thoughts out of their head, right? So thoughts come in and they tend to focus on them, focus on specific things, and then perseverating on them. So thinking about them over and over again. And so some researchers have speculated that this may be why the link between autism and depression is higher, because the way that their brain works tends to be more perseverative in general. And then we know that people who ruminate, who are perseverative, especially if they're perseverating on negative things, that is a big link to depression. So in the same way an individual with autism may focus on certain aspects of their environment, they also may begin to focus on negative experiences or feelings. So that's why some researchers think that depression is more common, is because in the same way they may become focused on some sort of sensory experience, they may also become focused on some sort of negative thought or negative experience and have a difficult time shifting their attention away from it. In addition, studies have shown that individuals on the autism spectrum may have a harder time with impulse control. So they may have a higher tendency to perseverate on negative experiences and less ability to kind of inhibit the perseveration. There's a lot of research on the executive functioning deficits in autism, which basically just means deficits in impulse control and attention and things like that. So that could play a role too if you have trouble with impulse control. If you already have a predisposition for those perseverative thoughts and your thoughts happen to be negative, then the rate of depression is likely going to be higher. So some of the hallmark characteristics of autism include the deficits in social communication and social interaction. These deficits may manifest as difficulties with back and forth conversation, difficulties making friendships, difficulties reading the nonverbal cues of others. All of those things can contribute to social isolation and withdrawal. And we know from just anecdotally that if we're withdrawn, if we're socially isolated, we need human connection as a species. We have evolved for millions of years as a social bunch. We millions of years ago lived in families, lived in clans, lived in tribes. We are a species that convenes together. We like community. It helps us survive. It's kind of a core hallmark of our species. So when we're socially isolated, when we have deficits in communication that make it difficult for us to maintain relationships and maintain friendships, then that can lead to that feeling of loneliness and isolation, of being misunderstood. All of those things can lead to depression. So even though many individuals on the spectrum struggle with aspects of our social world, most still long for a social connection and meaningful relationships. I see that definitely in my counseling practice. I feel like it's very common for young adults on the spectrum to seek out therapeutic help because they're struggling with that social realm and they so desperately long for the social connection. Imagine how difficult it would be if you are a young adult and you so badly want friendships and a romantic partner, and yet these skills do not come naturally to you. So how difficult that would be to navigate, the young adult experience, trying to get a job, trying to go to college. All of these things can be really tough for a kiddo on the spectrum who really wants to be like their peers and really struggles in certain areas that we see as a normal part of development. So a lot of the times I'm counseling young adults on the spectrum who really, really want social connection and social emotional wellness and can't quite get there on their own. So a really normal part, I think, for all young adults is to kind of find out who they are. And I definitely see that in my own practice with dealing with young adults who want social connection and aren't quite able to figure out how to get it on their own. And with autism, it's important to note that just because there's deficits in the social realm, it doesn't mean that that longing doesn't exist. We are social creatures. That's how our biology works. So just because there's these deficits doesn't mean that the child or the young adult doesn't really long for connection. And the connection might look different. The relationships with others might not look the same. And when we're talking about autism, but the desire to be understood and loved is universal. So I think we need to remember that just because someone's on the spectrum and they may be aloof from social interaction, it doesn't mean that they don't want to interact, don't want that community. Because in my experience, they really do, even though it might not seem that way on the outside. Okay, difficulties with diagnosis. So this is really geared more towards difficulties with diagnosis and autism specifically. I don't think depression is very hard to diagnose when we're thinking about the neurotypical population. It's actually probably one of the easier disorders to diagnose. A, because it's really common, so I see it all the time, and B, it's just very, the characteristics of depression are well known. People usually can verbally tell you about them. But when we're talking about autism, it gets a little sticky because many individuals on the spectrum have verbal deficits, right? So, they may have difficulty communicating verbally at all. They may be on the end of the spectrum that's nonverbal. So it could be anywhere from little to no speech, or you could have fluent speech with some communication challenges. There really is a spectrum, right? That's why we call it autism spectrum disorder, because people vary. Everybody is different. But individuals on the spectrum may struggle to tell you exactly how they're feeling, even if they're in pain. So that's kind of one of the symptoms, is that difficulty expressing, like we talked about in the previous webinar about anxiety, emotional regulation and the deficits there. Identifying emotions and understanding the emotions of themselves and others is not something that kiddos on the spectrum excel at. That is something that usually they need to work on. So that's what makes it really difficult if you're working with a kiddo who doesn't know how to express what they're feeling. How can you figure out what's going on? Another challenge is lack of affect. So this is kind of a hallmark symptom of autism that we see quite frequently, is the incongruence of the affective state. So usually when we are happy, we're smiling, we're excited. You can see it on our face. When we're sad, we, furrow our brow, we're upset, and you can tell how we feel based on our facial expressions. Well, that's not really the case in autism. It depends kid to kid, right, or an adult to an adult. But in general, this is a deficit where there's often affect incongruence, meaning that they may be really, really happy and look really flat, or they sometimes even do inappropriate affect where something's really, really sad and they start laughing. So that's pretty common, that affect incongruence, and it really kind of makes diagnosing really difficult, because if you have a kid who can't tell you what they're feeling, and then you have a kid who doesn't show affect on their face, or you can't read their affect appropriately, or if we don't have a good window into their soul, into their mind, what do we do? How do we tell how a kiddo is feeling? Most of the time we're hoping that with some training that the kid can tell us exactly how they're feeling and explain it to us. But if this is not the case, which isn't the case in some for some kiddos, what do we do? And we'll talk about that in the next slide. So a lot of the times especially with the nonverbal kiddos, we're going to rely on the behavioral markers of depression. So when I'm talking about behavioral markers, when you think about what I just talked about with the DSM and all the different symptoms of depression, we have low mood, we have anhedonia, which is like a loss of pleasure in activities, we have fatigue, we have all these different symptoms. Well, when we're talking about a nonverbal kiddo, or a kiddo who can't express what they're feeling, we're going to focus more on the behavioral markers, meaning has there been a change in appetite? Have they suddenly gone from eating pretty well to eating nearly nothing? Have they lost weight? Have they put on weight? Do they have the opposite effect where they're just consuming the whole kitchen? Has their sleep changed? Were they sleeping really well and suddenly they're not sleeping good at all? Anhedonia is like a huge behavioral marker. I probably should have mentioned that one first, but I didn't. So anhedonia is that loss of pleasure in activities. That's probably the biggest one I would look for if I were a parent. And if you have a kiddo who just loves Legos, just loves them, plays Legos all the time, and suddenly they're not interested in Legos anymore, and they haven't really interest change, right? Like they may not be interested in Legos and may move on to something else. I wouldn't be as concerned about that. But if they were only playing Legos and then suddenly no interest in Legos, but not really interested in anything else either, huge red flag for depression. We should find joy in the activities that we love to do, whatever those are. And interest change doesn't mean that you're going to love Legos forever. I certainly don't play with Legos, but we should find joy in the things that we're doing. Usually, especially as kiddos, we pretty much only do the activities that we like. Playing on the playground, running around, playing games, whatever it is, kiddos tend to just do the activities that they like and avoid the activities that they don't like. So if your kiddo suddenly, out of nowhere, isn't really doing anything that they like, moping around, seem really fatigued, not concentrating, not doing tasks anymore, and then you also see this change in appetite, change in sleep, those are some pretty significant symptoms of depression that I would definitely pay attention to. So anhedonia, I think the loss of pleasure in activities, huge behavioral marker of depression. And then the rest, if you see that, then I would pay attention to other stuff. Am I noticing sleep issues? Am I noticing appetite changes? Does he seem more mopey? Does he seem lethargic? Pay attention to the other stuff too. It's really difficult when we can't rely on a kid's self-report of mood. Very difficult to diagnose. But as parents, we know what's normal for our kid. You see your kid every day. You know what's normal for your loved ones. So if you see a change that feels off, pay attention to it, because it could be a behavioral marker of depression. All right, so now we're going to go into the treatment of depression. There's a lot of ways to treat depression, so I'm only going to focus on a few of my favorites today, and these are really geared towards autism specifically. The treatment for depression is the same for everyone. For instance, meaning that there's a cognitive behavioral therapy, and there's not a therapy that's like just for autism. The treatment for depression and autism is just taking little tidbits of other therapies that are already in use and modifying them for autism, if that makes sense. So the treatment, I'll just say that the treatment for depression is pretty much the same for everyone universally, but when you're dealing with autism, you just make special considerations. It's the same for anxiety. It's going to be the same for sleep. So I think that these webinars are really helpful to everyone, even though I'm focusing on autism and talking about autism specifically. The treatment is the same for everyone. So there's not a ton of research on treatments just for autism, just because there's no money in that, probably. So there's a lot of research on treatments for depression in general, but when we're talking about treating depression in just the autism spectrum disorder population, not a ton of research. But we do know that in general, people benefit from a combination of psychotherapy, which is like therapy with a psychologist or a therapist, and psychopharmacological intervention, which would be like taking medications. So in general, when we're thinking about depression, most people benefit from a combination of treatment with therapy and medication. There's a lot of research on this area. You can Google it, you can read the research. The combination of therapy and medication pretty much across the board is going to be your best bet. If you do medication alone is pretty much the worst thing. I mean, I won't say it's the worst thing you can do because that's not true. But if you're thinking about how am I going to treat this depression, combo is the best, followed by therapy alone, followed by medication alone. So if it were me and a loved one and they were asking me what to do about this low mood, I would say combo is going to be your best bet. Find a therapist, find a psychiatrist. I would never rely on medication alone because the treatment outcomes are pretty poor for that. So just a disclaimer, there's evidence that cognitive behavioral therapy is effective in treating comorbid depression symptoms in the ASD population. So cognitive behavioral therapy, which is often called CBT, is a therapy that's built upon a theory that what we think influences the way we feel and act, or more specifically, that thoughts, feelings, and behaviors are all related. So the idea of CBT is kind of if we change one of these things, if we can change the way we think, then we'll change the way we feel and behave. And they're all interrelated, right? That's why the arrows are pointed both ways, because changing one affects the other two, or changing two affects the other one. They're all related. So the cognitive in cognitive behavioral is changing your thoughts. So changing the way we think. The behavioral is trying to change our behaviors to get a better result. And the idea is that changing those things should lead to better feelings, that our mood should be better if we can change the way we think and change the way we behave, the things we do. There's a ton of research on CBT. There's also a lot of offshoots of CBT, which we'll talk about a couple of the offshoots. But in general, this is a really effective therapeutic approach that most therapists probably take bits of CBT. I would not say that I'm a CBT therapist, but I would say that I definitely take bits of CBT and incorporate them into my treatment. There are clinicians who adhere strictly to CBT. I just don't. That's not my style, and that's probably information for another webinar if you want to hear about that. But super effective, tons of research on the benefits of changing our thoughts to change the way we feel, to change our behaviors. Very effective, and CBT has been shown in the research to be effective with the ASD population. So what if let's think about CBT. I'm going to give you an example. Okay. So let's pretend that you have a big party to go to and you're getting ready for the party and you look in the mirror and you think, wow, I look terrible. No one's ever going to want to talk to me at this party. So this is a thought. This is a pretty negative thought, right? This is a cognition that you have. And if you think this way, a likely way that you might feel would be to feel insecure, sad, lonely, and then in feeling this way, it might affect your actions at this party. So if you're thinking, oh, I look terrible, no one likes me, I'm gonna have a terrible time at this party, then you feel sad, lonely, insecure, it's gonna affect maybe your behavior at the party. Maybe you're gonna stand in the corner in fear of judgment. Maybe you're gonna isolate yourself. Doing these behaviors, isolating, standing by yourself, not talking to anyone, is likely going to reinforce that feeling, right, of being lonely, of being sad, and it's probably going to affect your behavior in the future too, right? If you're at a party where you feel really terrible and then no one talks to you at that party because you've isolated yourself, you're going to be less likely to go to a party in the future, right? So that cognition at the beginning that I look terrible, no one ever is going to want to talk to me, has affected not only your feelings in the moment and your behavior at that party, but has probably affected your behavior for the future too. And then if you don't go to any parties, you don't meet any people, and you don't make relationships with people, and you don't make meaning out of your life. And the cascading of the events, negative events that can occur from that one thought is pretty powerful, right? So that's the idea of cognitive behavioral therapy, that these thoughts that we have a lot of power over our lives and make changes to how we behave and how we feel that can be really negative. So the idea of CBT is to try to take those thoughts and change them, and therefore change the way we feel and change the way we behave. So if you think about maybe changing the thought, what if when we had those negative cognitions, when we were looking in the mirror, getting ready for that party, what if we were able to challenge them in the moment? What if when we looked in the mirror, we said, you know what, there's no evidence that people won't talk to me at this party. I may feel that way right now, but when I really look at the situation, I've never been to a party where no one's talked to me. Usually when I go to parties, I have fun. Like, what if you were able to challenge that thought in the moment to be maybe a more balanced thought? You could have an attitude shift, right? And if you have an attitude shift, your feelings and your behaviors might also shift. And this is what CBT helps people do. It helps them change the way they think so that they can act and feel better in the moment and lead a more fulfilling life. It sounds really simple, and in a way, the theory is really simple. Changing our thoughts leads to changing our feelings and changing our behaviors. But this isn't really easy, right? If this were super easy, then I would not have a job. Changing the way we think is really difficult, and we let thoughts have so much power over us. And we'll talk a little bit about how to kind of diminish the power that our thoughts can have, but we are thinking beings. We are cognitive beings. We have this brain that we like to use, and sometimes it works against us. So in the case of depression, we have a lot of automatic negative thoughts that happen that then affect our behaviors and our actions and can really be detrimental to the way we feel. Okay, so another thing about cognitive behavioral therapy is the ABCs. So the ABCs has to do with antecedents. So those are events that happen, and then behaviors, which are, or the beliefs, sorry, is the B. B are the beliefs that we have about the events, the thoughts and the meanings that we place on the events. So in this little icon, I have attitudes, rules, demands, beliefs, images, meanings. So we have the events themselves, and then we have our thoughts, our beliefs about the events. And then we have C, the consequences of those beliefs. And those can be emotional consequences, those can be behavioral consequences. But basically the idea of cognitive behavioral therapy is that we have these events, we have the thoughts about the events themselves that leads to emotions and behaviors. So when we're thinking about the ABCs involved in the creation and the maintenance of depression symptoms, think about this. A young adult with autism spectrum disorder finds out that he's gotten passed up for yet another job. He's been trying for several months to get a job. He's been on several interviews, but hasn't been offered a position yet. Upon receiving the email that he's no longer in consideration for the position, which would be the activating event, right? Being passed up for a job. He has the following thought or belief. I'm a total failure. I'm never going to get a job. This leads him to feel pretty down for the rest of the day, which is an emotional consequence, right? And then he cancels plans that he had with friends for later in the evening, which would be a behavioral consequence. So that's kind of what CBT is identifying the activating event. What was it that made us feel bad? Identifying the thoughts that we had about that event, the things that we tell ourselves that are so powerful, and then the consequences. What was the aftermath of those thoughts? How do we feel? What did we then do with those feelings? So that's the idea of CBT. So CBTs are relatively structured psychotherapy. I said relatively, but I would say it's extremely structured. So CBT is basically manualized, meaning that you can follow a manual and do the psychotherapy. It has a lot of homework involved, a lot of psychoeducation is involved. So I think for our ASD population, it can actually work really well because it is so structured. It provides the patient with homework, it provides the patient with psychoeducation about different things. A classic CBT therapist would have like a whiteboard in their office where they're writing things down. Okay, tell me what the activating event was. Let's write that down. Okay, what were the thoughts? Let's write that down. So a CBT therapist, CBT therapy in general is very structured. So I think in a way it works really well with the autism community who likes structure, who likes organization. So it can be really effective. It's also a therapy that provides a lot of psychoeducation, which I think the ASD population really needs, about emotions, about identifying emotions, about identifying feelings in the moment and how we react to those feelings. So in a way, it can be very effective for the autism community. I think it's also important to note, though, I'm not a CBT traditionalist. And really the most important thing, and research has shown this day in and day out, is finding a therapist that you like. So even if your therapist doesn't do classic CBT, if you like your therapist, that leads to the best outcomes. It's just liking your therapist. It's been shown in a lot of research that the highest level of outcomes comes from just having a good relationship with your therapist. So now we're going to talk about mindfulness techniques. Mindfulness, I might kind of breeze over this because we talked about this in the anxiety webinar on Tuesday. So just a quick reminder, and if you didn't attend the anxiety one on Tuesday, I do go into mindfulness on that one. But the idea of mindfulness is taken from Buddhist traditions, so Eastern medicine that's been adapted to the Western mental health treatment. And the idea of mindfulness is to pay attention to the present moment with a non-judgmental, open-hearted, and curious attitude. So mindfulness teaches individuals to pay attention to experiences in their body, bodily sensations, feelings, thoughts, senses, and paying attention to them in the moment. So kind of to bring the mind back to the present moment. That's kind of what the idea of mindfulness is. Researchers show that mindfulness training may be successful in treating individuals with ASD because it helps treat some of the executive functioning deficits that are often present in the disorder. So executive functioning deficits, like I said, are like difficulties with impulse control, decision making. It's kind of all of our things that are happening in our frontal lobe. So when we have deficits in executive functioning, it's basically like a frontal lobe issue. So rather than paying excessive attention to certain details that attract attention for an individual on the spectrum, mindfulness would train you to view internal and external experiences as passing events instead of something that really needs to be paid attention to and perseverated on. So mindfulness can be a really helpful technique for autism, especially if they have that perseverative thought process, because mindfulness can kind of help you take a step back from that and see your wider field of awareness and what's really happening in the moment. So it can really help with executive functioning deficits as well. Mindfulness-based techniques, research shows, may improve social communication and social skills in individuals with ASD. Individuals who learn mindfulness are able to be aware of the present moment, including interactions with others. So if you're present in your interactions and you're not in your head thinking about other things, then you're going to have better social experiences, right? If you're better able to pay attention to social interactions instead of getting distracted by ruminations, it'll better help you attend to others. And by practicing awareness of our own emotions, mindfulness may lead to a better understanding of the emotional processes of ourselves and also of others. All right, cognitive diffusion is a component of a CBT offshoot called ACT, Acceptance and Commitment Therapy. It's a CBT offshoot in that it's still CBT, it's cognitive behavioral in nature, but it incorporates this mindfulness component into the treatment itself. ACT is also manualized, so you can like read books about ACT. It's super effective. It's actually got a lot of research that backs it up. The idea that I think ACT has that can really be incorporated into autism treatment of depression is the idea of cognitive diffusion. So cognitive diffusion is the idea that we all have a tendency to over-identify with our thoughts, just giving them way more power than they deserve, right? Sometimes when we have our thoughts, we think of them as truth, even though really they're just thoughts. Like thoughts don't necessarily mean they're true. So when we become so attached or fused to our thoughts in this way, it's easy to see how they can become so powerful. But in reality, thoughts are just thoughts. So the statement isn't meant to minimize the emotional impact that thoughts can have, because obviously thoughts can be very emotional. But thoughts are just thoughts. They're passing things. So in this little cartoon, thinking of thoughts as a passing train, right? So on the train, it's sad, mad, upset. These are thoughts that are coming into this girl's head. Oh, she can hear the train coming. And then she says, I can wait for the train to pass by, like it's a passing thought. And then I knew it would pass, now I feel better. So this idea that we can view thoughts as passing trains or passing things gives them less power over us. If we can kind of diffuse our thoughts from our feelings or our thoughts from truth, we give them less power, because in reality, we have tons of thoughts every day. Some are helpful, most are not. So cognitive diffusion can be like a really effective treatment and skill that we can teach our ASD population. So Russ Harris, who is an ACT guru, he's not the creator of ACT, but he's kind of a guru in ACT. He says, looking at thoughts rather than from thoughts. So looking at them instead of from them. So kind of seeing them like a train passing, right? Noticing thoughts rather than becoming caught up in thoughts. So noticing them. And then letting thoughts come and go rather than holding on to them. I know this is like a really abstract kind of technique, but it's very effective if you're someone who gets really bogged down in your cognitions and your thoughts. If your thoughts are super negative, then teaching this skill or learning this skill can be really effective for someone who, for anxiety too. Also ACT, side note, is really a great technique for chronic pain, because chronic pain, we can get really attached to, oh, I'm never gonna do this again. I'm so in pain, this pain's never gonna leave me. So ACT was really developed for chronic pain patients to help them kind of accept the pain and move through it and move on and do other things that they love to do. So treatment of depression in individuals with autism will be quite similar to the treatment of depression in the neurotypical population. Individuals on the spectrum may struggle with identifying their feelings of others, and part of the depression treatment would center on emotional awareness and the emotional regulation that are sometimes deficits in autism. With the few minutes that I have left, we're going to talk a little bit about psychopharmacological interventions. So like I said earlier, if it were a friend or family member asking me what to do about their depression, I would say, obviously, therapy, but also see a psychiatrist. So to me, I recommend seeing someone who's an expert in their field, and that's what a psychiatrist, is. So psychiatrists are MDs, they go to medical school, and they're experts in psychopharmacological treatment for mental health. I know that psychiatrists are extremely hard to find, especially if you're in a rural area. So I think just finding a provider that you trust who's willing to learn about your issues is key. So if psychiatry isn't available, find the next best thing. It's not always easy to find a good psychiatrist. To date, there's been no studies that determine the efficacy of SSRIs, which are selective serotonin reuptake inhibitors, on the autism population specifically. So they're prescribed, like a Prozac or something would be prescribed for depression. There's no research that really looks at autism and SSRIs specifically, but in general, SSRIs are the mode of treatment, psychopharm, for depression. In general, though, they're helpful. I think it's just we need to pay attention to possible side effects, because side effects can be worse in the ASD population. For behavior or irritability, the FDA only has 2 approved medications for behavior, which are atypical antipsychotic medications of Abilify and Risperdal. So if there's no behavioral issues, they're probably going to focus on the SSRIs. If there's like some behavioral irritability, self-harm, things like that, they may prescribe an antipsychotic. But really, research shows that there's no one-size-fits-all treatment for depression. You know, ideally, you'd want to go to someone who's going to tailor a treatment plan for you that likely includes both therapeutic techniques as well as psychopharmacological intervention. And like I said earlier, psychopharm alone, so just medications alone, is going to be like the worst of the 3 options you have. I guess 4 options if you include doing nothing. I would not do medicine alone. I would combine therapy and medicine, or I would do therapy and other self-help things like yoga. I would not just take meds personally, and I never recommend it for my clients either. All right, a few quick resources. So here is that Harvard study that I talked about earlier, and then the TED Talk that is related, What Makes a Good Life, Lessons from the Longest Study on Happiness. Super interesting, I think. It's always interesting to me, these longitudinal studies on longevity, because there's information coming out every year about what leads to a long and healthy life, and it's fascinating to me. So this study specifically, following people for 80 plus years, found that relationships are really effective for longevity. So super interesting. The other couple things, ACT, there are several apps on ACT. So there's the ACT Companion, which is written by Russ Harris, who's an ACT guru, who has several books that he's written on ACT. So there's an app that accompanies those books. And then there's also the ACT Coach, which is an app that was developed by the VA, I think the Veterans Administration on PTSD maybe. But both are very good if you are someone who wants to kind of self-help and use technology. The books are really good though. Russ Harris's books are really good. And you can always pick up just on Amazon, a book. I think his book is like The Happiness Trap, I think, Russ Harris. Very good though, very well reviewed. And then the apps would just be companion to that. But if you're someone who has depression, it's definitely something that I would get treatment for because of the possibility that you would start feeling really down and wanting to hurt yourself. So just a disclaimer there that if you're someone who's feeling depressed, to seek out some help. All right, I think that is it for today. I ran out of time for questions again, so I'll be back on Tuesday for my webinar on sleep, which I'm super excited about. If you have questions on today's webinar, email this info at johnson-center.org, and I'll answer them at the beginning of Tuesday's webinar. Thanks so much for joining me, and if you feel so inclined, please come back on Tuesday, and I'll be here talking about sleep and how to have better sleep and why we don't sleep very well, all of those things. So thanks so much, and I'll see you Tuesday.